on the need of capsular tension ring and other capsular tension devices in cases of pseudoexfoliation. Can you see my screen?
Yes,
Can
yes,
you hear me, ma'am?
yeah.
Okay. Great.
No,
We
please.
all know that, yeah. So we all know that pseudoexfoliation syndrome is an age-related disorder of the extracellular matrix. Uh, just a minute, ma'am. Okay. And there is pathologic progressive accumulation and gradual deposition of gray and white fibrillar material on various ocular structures like lens capsule, pupillary border, ciliary body, zonules, trabeculomeshwork, and endothelium. So this is how the typical pseudoexfoliation in the eye looks like. So we need to dilate the pupil and see, because many times we may miss the pseudoexfoliation which is there in the eyes. And this is the classic three-ring sign which is seen in a case of pseudoexfoliation. There is the fibrillar material on the pupillary border, followed by a clear zone, which is because of the rubbing of the back of the iris surface on the lens capsule. And again, there is fibrillar material deposit which is seen. So why pseudoexfoliation affects the cataract surgery? Because there may be intraoperative and postoperative complications because of that. It basically weakens capsule and zonular apparatus secondary to progressive proteolytic disintegration of the suspensory ligament of the lens. And most importantly, degree of pseudoexfoliation material visible in the eye, it does not seem to correlate with the degree of zonular weakness. So these are the various capsular tension devices which may be required in the cases of pseudoexfoliation, ranging from the simple CTR ring, capsular tension ring, which is a horseshoe shaped ring made of PMMA which has two eyelets. And there is one Henderson CTR ring which you can see, it has undulations. It facilitates the easier cortical matter removal. Or we may need modified CTR ring or Sione ring, or we may require capsular tension segment if we don't want to use the Sione ring. So these CTR rings were first described by Hara et al. In 1991, and it works by creating tension within the capsular bed to support an area of zonular weakness via recruitment of surrounding intact zonular fibers. So how do we plan surgically these cases? If we have a non-dilating pupil, we may need to use iris hooks or rings in these cases. If we have a mild zonular weakness, or if the dialysis is less than 4 clock hours, CTR ring alone can suffice in those cases. But if there is moderate to severe zonular weakness, or there is greater than 4 clock hours of dialysis, CTR alone will not suffice. We need Sione CTR to fix the CTR with the sclera, or we need CTR along with capsular tension segment, and along with them we may require capsular hook to provide stability to capsular bag during surgery. Timing of CTR placement is very crucial. So the dictum is we should use CTR as late as possible, but as early as needed. So in mild cases of pseudoexfoliation or mild cases of zonal laxity, we mostly use the CTR after doing phaco and cortical removal, but in severe cases we use them after capsulorhexis. So there may be some complication which may occur while implanting the CTR ring. There may be accidental anterior capsule tear or posterior capsule rupture and dislocation of CTR. And in fact, if we have any of these conditions, CTR should not be used. So this is the Henderson CTR. As I said, it has 8 equally spaced indentations. So only advantage over the standard CTR is that it allows easier removal of the cortical matter. So CTR ring, it comes in 3 sizes. So in the typical normalized, we use the 12 by 10. That's the uncompressed and compressed diameter of the ring. For highly myopic eye, we use the 14-12 millimeter size of the ring. If you look at the capsular tension segment, it is made of the, again, PMMA, but it has an eyelet and a hook which is protruding in the center, and it lies above the anterior capsule, so that we can use it temporarily or for a permanent fixation. Another advantage of capsular tension segment is that we can use these devices if we have a anterior capsule tear or a posterior capsule tear, and we may use 1 or 2 capsular tension segment depending on the need. So let's go to the videos. Just a minute. Okay. So here there are various ways we can implant this CTR ring. This is the implantation using this injector. So we thread this thread this ring in the injector, and the leading eyelid. This is the case in which the malignant ring was also used to dilate the pupil. So once the leading eyelet goes in, we keep on pushing the ring, and we use the second instrument like Kuegelin's hook or any dialer kind of instrument to release the trailing eyelet. So once it goes in the capsular bag, it stabilizes the capsular bag. This is a freehand technique of implanting the CTR ring. We go from the side port incision, and we use again the Kuegelin's hook to just guide this ring, and once it goes inside, it stabilizes. So this is a case which has more than 4 clock hour of zonal laxity. So we use capsular hook first to stabilize the capsular bag, which gives the anterior-posterior stability. And once you have stabilized it, you do phaco, take off all the nuclear and cortical matter, and put the CTR ring in. And once CTR ring provides stability, here I'm using a capsular tension segment with 90 proline. You may also use Gore-Tex suture. So once this segment is put and it's tied to the sclera, it provides a good centration and long-term stability to the capsular bag. So I think if we have a planned approach using various capsular tension devices in these cases, it can give satisfactory results in short and long term. Thank you very much, ma'am.
Thank you. Dr. Haripriya, I see you are there. I have a question for you. Can you unmute, Dr. Haripriya?
Yes.
Yeah. Now, if there is a more significant pseudoexfoliation, would you actually consider keeping the haptic in the sulcus and optic in the bag kind of a situation? Do you feel that there is a role for that?
Absolutely. So I think that is a good placement to have the IOL placed in the sulcus. You do your phaco, place the CTR, but place the IOL in the sulcus and capture the optic in the rexus. So I find that actually gives the IOL good stability long term as well.
Again, if you've had a toric IOL which has rotated in one eye of a myope, would you actually, theoretically, we know that equatorial friction is less in a large capsular bag. Would you think of placing a CTR in the other eye? Honest answer.
I would, but I'm not sure if it really helps too much, just placing a CTR. In spite of it, you still may have the same issue with IOL rotation.
Okay, I want a question to you and Gaurav again, or even Harshul. Do you think that it's the present day small rexus and the pseudoexfoliation which actually could be causing the anterior lens capsular contracture and progressive capsular weakness? Because those days when there were those scan opener capsulotomy which was done, I don't remember seeing so many subluxations of the IOL into the vitreous or dislocation of the IOL bag complex. Could it be that creating a small rexus there's greater contracture? Your thoughts?
Definitely. So I think once you have a smaller rexus, the chance of contraction is much higher. So even if you're making a small rexus, I would suggest at least making a nick at the end of the surgery. So then you kind of relax the contraction process, and this will help preventing contraction. If not, do a YAG in the early postoperative period.
Harshul, yes?
Yeah. So I always believe in making a perfect capsular rexus. Even if it's small in the beginning, once you put your CTR ring, once you implanted the IOL, you can go and enlarge the rexus by giving nick with the micro scissors and have an adequate size capsular rexus, which is very less prone for capsular phimosis. And earliest you see it starts contracting, you can use the laser, YAG laser, to give, as ma'am said, you can give the relaxing incision so that the further subluxation of the IOL bag complex won't happen.
So I think we still continue at the end of the talk with a lack of clarity whether CTR placement in a young pseudoexfoliative eye actually makes sense, especially in torics and premium IOL. It is something which we would take a decision on a case-to-case basis. I hope, do hope my panelists agree on that. Dr. Haripriya?
Yes, I do.
Yeah. Why not do reverse optic capture for the other eye patients with high myopia?
I would be coming back to you on that